So thank you very much for the introduction, and thank you for inviting me to this fantastic meeting. It's a pleasure to be here in Puebla, Mexico, and I hope you will enjoy my talk. I've been given the task to talk about new insights in irritable bowel syndrome, food, bugs, leaky gut, inflammation, brain, and beyond. So the talk will focus on pathophysiology, and tomorrow there will be another talk where I will expand a little bit more on this and also link the pathophysiology to treatment of IBS. So this is an overview of how we view the pathophysiology of IBS today. So we have what we can call some kind of predisposing factors that you see over here, and these might lead to or affect the main pathophysiological factors that you see over here: abnormal central processing of sensations, psychological disturbances, gastrointestinal motor disturbances, visual hypersensitivity, immune dysfunction, serotonin, increased intestinal permeability, and old microbiota, and some others. And there are also trigger factors that you see over here that can affect these different pathophysiological factors and then lead to symptoms. Food, for instance, is one of these trigger factors, stress and coping. So when it comes to research on pathogenesis and pathophysiology on different diseases, and just like the same is true in IBS, there are of course trends, what is popular at the time. And you can see a timeline here when it comes to the trends on the research on the pathogenesis, pathophysiology of IBS. And as you see over here, what is popular right now, which with a lot of focus on, is food and diet, brain-gut interactions, microflora and inflammation, and those are some of the main topics that I will touch upon in this talk. The majority of the talk will focus actually on what you can call the microenvironment in IBS, and there has been a lot of different studies during the last couple of years focusing on this microenvironment. For instance, the role of the gut microbiota, the role of bile acids in the pathophysiology of IBS, more and more interested in the role of different food items in IBS, mucosal immune activation, increased mucosal permeability, and also how this gut microenvironment interacts with the brain. When you think about this gut microenvironment, these different factors do not work in isolation. Of course, they work together in what you can call a mucosal crosstalk, which is highlighted on this slide. And as I said already, we will focus on some of these factors involved in this mucosal crosstalk during the talk. For instance, then the immune activity, which will come first, the role of bile acids in food, and also the role of the intestinal barrier and the underlying immune system. But what is the problem today with many of the research studies that we have performed is that we have looked at one of these factors in isolation. So what is happening right now is that we try to look at these factors, how they interact with each other and how that might lead to symptoms. And I think that's the way forward to really understand the pathophysiology of IBS better, to see how these factors interact in patients with IBS compared with healthy controls. So starting off with the immune function, as you probably know, there are a lot of different studies that have focused on the role of immune function, or what you can call a low-grade inflammation in IBS. And there are indeed a lot of studies that have demonstrated that there seems to be an upregulation of the immune activity in IBS compared with healthy controls, as exemplified here by one study from an Italian group where they looked at the number of immune cells, or the proportion of immune cells per high power field in a biopsy from the colon. And you can see that there seems to be an upregulation of the immune function in IBS compared to what you can call the physiologic inflammation that you see in healthy controls. But you can also see that this is clearly different from the true inflammatory disorders. And if you summarize what has been found so far in IBS, there has mainly been a focus on, there have been found abnormalities when it comes to lymphocytes and mast cells, but not when it comes to neutrophils, which of course is the main player in what you call true inflammation. So we prefer to call it that there is an upregulated immune activity in IBS rather than saying that this is the true inflammation. What is important is that all of these different immune cells, such as the mast cells, T cells, etc., and can interact with the nerve function in the gut through different products such as the cytokines, histamine, serotonin, etc. And through these mechanisms, through these mediators, they can interact with receptors and channels on different nerves and then affect symptoms through this interaction. So this is another very interesting looking at these neuroimmune interactions, which I think are of great relevance to at least a subset of patients with IBS. Moving on then to intestinal barrier, which is another important research area in IBS today. And this is an overview of the intestinal barrier within the gut. And there are, of course, different components of this intestinal barrier. Of course, the cells per se are very important in the barrier function to prevent different dangerous molecules to go through the cells and interact with the underlying mucosa. There are, of course, also these tight junctions that are very important, but also, of course, the very thick mucus layer which is present in the gut to protect us from the dangerous environment within the gut lumen. So far, studies in IBS have mainly used different probes to look at the permeability, for instance, different sugars, and thereby also after that see when they appear in the urine as a measure of permeability, or focusing on biopsies, mainly then measuring the tight junctions. And there are studies that have demonstrated alterations in permeability using both of these different techniques. But so far, no studies have actually looked at this very important mucus layer, and I think that's also a very important mechanism that needs to be explored in the future, and we are currently doing some research in that area. This is one example of a study where they looked at small intestinal and large intestinal permeability in IBS. In this particular study, they were able to demonstrate that patients with IBS, both diarrhea-predominant IBS and post-infection IBS, had increased small intestinal permeability compared to healthy controls. And there are numerous other studies that have actually demonstrated this. So patients with IBS seem to have an abnormal intestinal permeability, at least at group level. But whether it's there at the individual level is more uncertain. So now we'll move on to microbiota, which is, of course, a very hot topic in IBS, just like in, I would say, all other diseases today. You who work as clinicians are probably familiar with some of the clinical scenarios that clearly link IBS to the gut microbiota. For instance, I guess you've seen patients who come to you after a bout of gastroenteritis and they have developed IBS, what we call post-infection IBS. So we think that approximately 10% of subjects who have a gastroenteritis will develop some kind of long-standing bowel dysfunction compatible with IBS. And there are some risk factors that increase the risk of developing post-infection IBS after gastroenteritis. Another clinical scenario that you're probably familiar with as well is the development of what you can call a dysbiosis after the course of systemic antibiotics for instance, an ENT infection or something. Some patients may develop some gut symptoms after that we probably try to link to development of a dysbiosis, and some of them actually may also develop functional GI symptoms compatible with IBS. On the positive side, we also have some treatments where we can modulate the gut microbiota and thereby improve symptoms, such as use of probiotics and non-absorbable antibiotics, such as rifaximin. So there are several clinical scenarios actually linking IBS to gut microbiota. But how can the gut microbiota then lead to symptoms in patients with IBS? Well, we don't really know the whole story there, but theoretically there are, of course, different ways through which the gut microbiota might lead to symptoms in IBS. Of course, it can happen through the activity within the lumen, interaction with food, bile, etc., and through production then of different products such as short-chain fatty acids, gas production, and so forth, and that might lead to symptoms. But probably of greater importance is the possibility of the gut microbiota or products from the gut microbiota with the barrier function, with the underlying immune system, and then through gut-brain interactions. But here I think we need to do a lot more in order to really understand how gut microbiota can lead to symptoms in IBS and also in other diseases. When it comes to research on gut microbiota in IBS and healthy controls, there are a lot of studies that have looked at the difference in the composition of gut microbiota between IBS patients and healthy controls. And here are two of the more recent, relatively large-scale studies on gut microbiota in healthy controls. And the take-home message from this slide is that it seems to be the case that there is a subset of IBS patients that have an abnormal gut microbiota composition, rather than having a specific gut microbiota characterizing the whole IBS group. This was exemplified in this study that we did together with the core group led by Eamon Quigley. where we found that a subset of IBS patients, which is in red here, actually had a gut microbiota that was different from the healthy controls. But you can also see here in green and blue an overlap between what we can call a healthy gut, IBS group, which had actually a gut microbiota that was indistinguishable from the healthy controls. So a subset of IBS patients had abnormal gut microbiota. The same holds true for this study from Robin Spiller in Nottingham, together with Willem de Vos from Holland, where they looked at patients with post-infection IBS and also diarrhea-predominant IBS. And they could see more of a spectrum of gut microbiota composition, ranging from the healthy gut microbiota to the clearly abnormal gut microbiota in a subset of patients with IBS. But as you see, a big overlap here between healthy controls and IBS patients. So more of a gradient from the healthy gut microbiota towards the IBS characteristic gut microbiota in a subset of patients. This is a summary slide from our most recent gut microbiota study published earlier this year in collaboration with a French group, where we tried to identify what we call a gut microbial signature linked to the IBS symptom severity. So what we did, we had an exploratory cohort, and then we also had a validation cohort. We took both biopsies and fecal samples, and using advanced statistical methods, we tried to identify a gut microbial signature that could characterize severe IBS and distinguish patients with severe IBS from healthy controls and patients with IBS with more moderate or mild symptoms. And we could identify a gut microbiota consisting of 90 different bacterial species that could identify and separate these groups. And then we did the same exercise in the validation cohort using these 90 bacteria, and we could again separate severe IBS from healthy controls and the mild cases of IBS. And this gut microbiota signature was also associated with the low microbial richness, low methane productions, and low absence of methanogens, but also linked to the enterotype. So the bacterioids enterotype was enriched in this group of patients. So we think this is quite interesting. I think this is one way towards what you can call finding some kind of biomarker for IBS. Of course, we have a long way to go, but I think we need to use, well-characterized patients. We need to characterize the gut microbiota in a good way, but we also need to use modern statistical approaches to really take the best out of our data. So I think there is more to come here when it comes to gut microbiota and the link to symptoms in IBS. A few words about bile acids. I think this is a neglected factor within the pathophysiology of IBS. As you probably know, if the bile acids leak into the colon, they will cause diarrhea through effects on secretion and motility. And if you look at patients with diarrhea predominant IBS, actually up to 25% of them have an increased bile acid loss into the colon. And you can do that by evaluate that through using a CCAT test, which is a test of the enterohepatic circulation. And if you have a low value, below 10%, this indicates that you have an increased bile acid loss into the colon. Of course, if you have Crohn's patients with ileal resection, all of them will have increased bile acid loss. But as you can see, also a substantial number of IBS patients will lose bile acids into the colon, and this will lead to diarrhea and symptoms related to that. We looked at the mixed group of patients with IBS and looked at the colonic bile acid exposure. We again used this CCAT test, where a low value indicates that they have an increased bile acid loss into the colon. And we actually found that both patients with alternating type IBS and diarrhea predominant IBS have increased loss of bile acids into the colon. And this was associated with accelerated colonic transit, associated also with increased stool frequency, looser stools, and as I said, accelerated left colonic transit. So this is something that you can look for in the clinic, especially in your patients with diarrhea predominant IBS. And as you know, we can treat this with bile acid binding agents quite effectively in the clinic. The last part of my talk will deal with food, which is a very central issue for patients with IBS. Most of our patients try to link what they eat with their symptoms, and many of them claim that there actually is a clear association between food intake and exacerbation of symptoms. And this is also something that you can see when you do different questionnaire studies, that actually the majority of patients with IBS can actually link meal or food intake with exacerbation or worsening of their symptoms. And also if you give patients, here in this case, a standardized Swedish breakfast, and you follow the symptoms over a couple of hours, you can see that the symptom response is clearly exaggerated in the IBS patients. Without going into any details about the individual symptoms, you can see that most of these severity symptom ratings are higher after a meal in patients with IBS. So there seems to be a link between food intake and symptom exacerbation in patients with IBS. And if you ask patients if they really can link symptoms with food with different symptoms, actually the majority of them actually report that they report GI symptoms after at least one of the food items that we surveyed in this study. And this was true especially for food containing incompletely absorbed carbohydrates and fat. And there was also a link between the perceived food intolerance and the severity of symptoms. So food is central to patients with IBS. The next slide, I don't want to scare you with this one, but this is just to show you how complex food and symptoms are in the GI tract. So there are several different mechanisms through which food can actually lead to symptoms in IBS. And I encourage you to read this very nice review by Roberto De Giorgi, where he tries to summarize how actually different food items can lead to symptoms. You can see that it can affect the permeability, it can affect the immune function, and a lot of other functions as well. But what is most popular today is probably this route, where carbohydrates, the so-called FODMAPs, can interact with gut microbiota, lead to fermentation, gas production, and luminal distension, and then lead to symptoms. And I will highlight that on the coming slides. So this is a proof of concept study actually showing that the poorly absorbed carbohydrates, that is the FODMAP, the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, are relevant for symptom generation in IBS. So what these authors did in this study was that they put patients with IBS and fructose malabsorption on a low FODMAP diet. Then they challenged them with different FODMAPs, fructose, fructans, or a combination of fructose and fructans, and then as a control, glucose, which is not a FODMAP. And as you can see here, when they challenged them on top of this low FODMAP diet with these different drinks, when they had the control solution, clearly higher proportion of the patients had adequate symptom control compared to when they were challenged with these different FODMAPs. And also, if you look at the individual symptoms, the symptoms were clearly higher when they were challenged with these in a blinded fashion with these FODMAPs. So yes, FODMAPs can definitely produce symptoms in IBS. And there are now, as you probably know, several studies that have actually looked at the relevance of a low FODMAP diet for patients with IBS compared with a control diet. And here you can see that with the low FODMAP diet, the symptoms are clearly better compared with a control diet. In this case, it's typical Australian diet. And here you see a summary how this works. These carbohydrates, they pass unabsorbed through the small intestine. When they come into the large intestine, they meet bacteria, which leads to fermentation and gas production, and also through osmosis, drags water into the lumen. This leads to luminal distension, and in a susceptible individual, this might lead to symptoms. But it's not just about what happens in the gut when it comes to gastrointestinal symptoms after meal intake. And this was shown in this study that we did together with the Leuven group led by Jan Tack. And what we did here, we served them this famous Swedish breakfast. This is what we eat for breakfast in Sweden. It looks very nice, doesn't it? It's porridge, hard bread, cheese, apple juice, and milk. This is, of course, a standardized breakfast, but we don't eat it every day. But that's okay to eat it every now and then. And we follow the symptoms over 4 hours, as you can see here. And what we did was we divided the patients into different severity categories based on their psychological symptoms. So you see here, with increasing levels of anxiety, they reported more severe symptoms. And also with increasing levels of somatization, there was an upregulation of these symptoms reporting, but also an exaggerated postprandial symptom response. So the brain-gut interaction seems also to be of great importance. So you probably need to pay a lot of attention also to the psychological symptoms when you treat postprandial symptoms. And that leads me to the last few slides on my talk, which will show you the importance of brain-gut axis, which I think you're quite familiar with. The brain-gut axis interactions are very important when it comes to patients with IBS, partly through the upregulation of what you see here, ascending visual pain pathways, which has been demonstrated in IBS. Also abnormalities in how the brain interprets signal from the gut, but also, importantly, the abnormalities in what we call the descending visual pain pathways, which should actually block noise from coming up to the brain. There are also abnormalities in those pathways in IBS. And there are, as you probably know, a lot of brain imaging studies that have actually demonstrated differences in brain activation between patients with IBS and health controls, and it's summarized here. But I think what we need to do now is something that we and others are doing. We are trying to link these different factors together, and this is a collaboration with the UCLA group, where we actually looked at the interaction between the gut microbiota, the brain function, and also physiological and behavioral measures in the GI tract. And we actually found a quite interesting three-way interaction between these factors. And I think we need to increase the complexity in what we're doing, because symptom generation in the human body is very complex, and I think we need to acknowledge that. So to summarize, we have learned a lot of things during the last couple of years when it comes to pathophysiology of IBS. We still need to learn more in order to improve the treatment for our patients. Brain-gut interactions are of great importance, and there are several different factors that are highlighted here that are of importance, at least in subsets of IBS patients. And I hope that I will see you on the talk tomorrow, where we try to elaborate on this, how this may then lead to better treatment options for patients with IBS. So thank you very much for your attention.